I think we had a fantastic opening session. It really showed us the breadth of what's going on, both in sustainability, but also in promoting innovation. And so this session, as Keith's put up, we're actually going to focus on something different. Environmental impact, first with Sharon and then with Kelly, and then moving on to pick up that thread that we started to talk about last time around circularity in the supply chain from Andy and Shaheen. So it's a great pleasure to start by introducing Sharon Flager. When I think about pharmaceuticals and the environment, it's hard to not think of Sharon and all the fantastic work she and her colleagues have done in Scotland and beyond. And as you probably know, she's a consultant in pharmaceutical public health. And I'm going to pass over to Sharon to present her work and tell us a little bit more about this area, because you've done so much brilliant work. It's fantastic to hear from you, Sharon. Over to you.
Thank you, Fiona, for that kind invitation. As Fiona said, I'm a public health consultant. I specialise in the use of pharmaceuticals at population level. And for the last 7 years, I've been thinking about what the pharmaceuticals we give to our patients actually do to our environment. So today I'm going to talk to you about the One Health Breakthrough Partnership and the work that we have been doing. So just a quick introduction about medicines. I'm sure most of us already know that the prescription of a medicine is the most common thing that we do to patients in healthcare in the UK and across the world. It's big money too. We spend about £22 billion a year on medicines in the UK. And of course, those medicines are designed to have a biological effect on our patients. That's why we give them to them. But what we don't realise too often is that once they leave our body, once we pee and poo them into our toilets or chuck waste medicines into our toilets, that they actually continue to have that effect in the environment. So they enter through our wastewater treatment plants mainly, also septic tanks, of course, and from industry too. But our wastewater treatment plants were never ever designed to deal with really small, complex chemical molecules. So they don't get completely removed. In fact, sometimes they don't get removed at all, and they end up coming out in our surface water, entering our rivers and our oceans and causing issues there with biodiversity and pollution. And I know today we've been talking mainly about the net zero agenda, but I want to introduce you to the triple planetary crisis agenda, which is actually climate change, loss of biodiversity and pollution. So today I'm focusing on the latter two. And I could spend this whole talk talking to you about what pharmaceuticals actually do, but just in this one slide, I'm just going to show you that they can actually feminize male fish. That leads to population collapse of our fish populations. They change reproduction, physiology, behaviour, and they potentially contaminate our raw water sources from where we get drinking water across the world, and also our food chains. But really importantly for us in the healthcare system, they also help assist in the spread of antimicrobial resistance. And as we know, that is our biggest public health threat that we face, with up to 10 million deaths predicted by 2050 every single year. So about 7 years ago, I helped to co-found this partnership, the One Health Breakthrough Partnership. It's a collaboration between our environmental agency, our water company, the NHS and our academic partners. We work and live in a beautiful part of the UK in the Highlands of Scotland. We rely on water a lot for our economy, for our tourism, for our production of whiskey and gin, of course, our salmon and other shellfish that we fish. So our vision is to have a non-toxic environment for all of that to happen in. And our mission is to reduce the environmental impact of healthcare practices, because we all know about the 25% of medicines causing a net zero problem, but we're not doing much about the pollution. We want to also influence policy, drive research and innovation, and you'll see later in my presentation that we have actually made a change in policy already in Scotland. I hope you can find the website and the QR codes helpful for my presentation, and maybe checking some of the resources that I'm going to quickly speak about today. So today I thought I'd just talk about 5 major parts of our work. We've got a lot more work and papers and webinars on our website, but I'm going to start off with these ones today. So Caithness General Hospital, as you can see on the map there, is the furthest north mainland hospital in the UK. And in 2017, we did a source to sink project in Caithness Hospital, and we tested the water coming into the hospital, the water coming out of the hospital, and the water going in and out of our water treatment plant, just to find out what the pharmaceutical loading in it was. We tested for 8 compounds and we found 7 of them in the mid to high nanogram per litre in our hospital discharge. But actually what we did find was that the medicines were all also in the effluent of the wastewater treatment plant. And that means the water that has been treated and is being pumped into our rivers and oceans. And looking at the removal rates, I'd said before they were never designed to remove pharmaceuticals. Looking at our removal rates, we got anything between less than 0. That means they actually increased the amount of pharmaceutical pollution in the water treatment plant to about more than 80%. So that's really dependent on the pharmaceutical and dependent on the rainfall, etc., through the treatment plant. So we found out what was going on at local level, and we then worked with the Alliance for Water Stewardship, which is basically a fair trade stamp for water use in businesses around the world. And we have a system there with AWS that actually drives, recognises and rewards good water stewardship performance. So we worked with them and we achieved the first hospital in the world to be good water stewards, from starting off at that first baseline experiment and then creating a plan about how we were going to improve our water use going forward. And we're still the only hospital in the world 6 years later to have that award. So we knew what was going on in one of our hospitals, but what was going on in our whole country? So we decided to look at every piece of research that had been done in pharmaceuticals in the environment over a 5-year period, and also all monitoring, whether statutory or voluntary, that had been done as well. We ended up with about 48,000 data points of 61 pharmaceuticals that had been researched or monitored. And we identified lots of monitoring gaps, but also potential environmental risks. We now know that any level of substance can actually start to have an effect in the environment, but we have something called the PNEC, the predicted no effect concentration of pharmaceuticals in the environment, and we found 9 substances that were above this, and worryingly 3 of those were antibiotics. So again, pushing us towards that developing AMR picture. So we had our 48,000 data points, but how could we make them look better? So what we did was then develop a data visualization tool, and we think again that this is a world first. So we put all of those data for how much of the pharmaceutical, what pharmaceutical, where was it found, into a GIS tool, and we also combined it with our national community level, so primary care prescribing data for those 60 substances. And we can now start to interrogate that database and see if there's any relationship to what's being prescribed right down to a GP practice level, or a health board or national. Is there a relationship for what's being prescribed and actually what we're finding in the water? And if we do find that relationship, then we can think of interventions to actually decrease the pharmaceutical load and to decrease the impact on the environment. It's tricky, isn't it, with all our climate change actions, because quite often we're starting out to do things, but we don't have the policy there to support us. So what we did with one of my PhD students was actually to do to look at the current policy landscape and suggest what policy options might be available to us to actually help our prescribers do greener prescribing. We call it eco-directed pharmaceutical prescribing, but actually what that means is prescribe less toxic medicines for the environment. Because quite often we can have 2 drugs that do the same thing for the patient. They cost the same for the NHS, but surprisingly, one of them is much more toxic to the environment than the other. So if they both do the same, they cost the same, let's choose the one that's better for the patient and better for the planet. So we have that publication, which is very interesting. It's all about, again, bringing those key stakeholders together, including some environmental criteria in our formulary decision-making processes, and also calls for a lot more education for healthcare professionals and for the public on the issue of pharmaceuticals in the environment. So that led us on having that policy gap done and having our visualization tool with all the data in it led us on to being awarded a Medical Research Council bid. This was a proof of concept bid, but what we did was to develop a framework for eco-directed sustainable prescribing. Essentially just what I've said. So can we actually put environmental data alongside our clinical and cost effectiveness data, stick that into a model and see whether we can discover what the risks are from certain medicines, and then the action from that would be to potentially change that drug B to drug A because it's less toxic on the environment but still is good for the patient. So what we did was we did Bayesian modelling. We got healthcare professionals and environmental scientists to work together to develop the indicators. So what was important for what we chose, which drugs were the most important, and then we put that into a decision-making Bayesian network model. We now have GIS maps that we can show the risk of a medicine all across Scotland. But most importantly as well, we worked with our prescribers and also our public in focus groups to talk to them about the environmental impact of medicines. Did they know about it? What did they think about it? How could they think that we could make things better? How could we prevent our medicines that we prescribe in the NHS from actually making our environment sicker? So this was a really interesting and exciting project for us. It's the first time that anything has been done along these lines in the UK. I would tell you shockingly that evidence on pharmaceuticals polluting our environment has been around since the 1950s. That's probably older than anyone listening in on this call, but yet we're not doing anything about it really in our healthcare system. There has been some work done in Sweden, and we're obviously working with Stockholm City Council and Uppsala University in moving forward the work that they did. But in the UK, it's the first time that we've done this. It actually helps us progress towards our national sustainability policies and targets. In Scotland, we actually have water stewardship and pharmaceutical pollution as part of our climate change and sustainability strategy. And I think most of all, in the One Health Breakthrough Partnership for the past number of years, we know that we all bring from every organisation a different perspective to this. No one of us can fix this problem. It needs everybody working together to do that. So it really has demonstrated the power of this transdisciplinary approach, bringing prescribing, environmental and social science people and methods together to investigate the issue. The impact, now I think it's got super potential to have impact, not just in Scotland, not just in the UK, but right across the world. Prescribing rates, prescribing money spent, they're all increasing across the world for a number of reasons. We have an aging population. The older you get, the more prescription medicines you tend to have. By the age of 85, you're often on about 20 medicines a day. So we need to change our prescribing practices in many ways, but if we still do need to prescribe a medicine to a patient, then we do need to think about the environmental health as well as our patients' health. I've been speaking with Scottish Medicines Consortium and NICE, trying to think about getting this into health technology assessment as well, because the reason that most clinicians say to me they can't make a change in their practice is because they haven't simply got the information. There are environmental risk assessments from industry, but they are hard to access, and our clinicians haven't got time to sit and read through reams of paper on every prescription drug that they are going to prescribe. So hopefully, thinking to the future, we will see a health technology assessment process that actually thinks about carbon footprint and thinks about environmental footprint as well, pharmaceutical pollution into our medicines, and gives us that information at the top of the tree rather than having our clinicians spend time on that. I also think raising this issue will actually help us to change societal culture. We tend to have a society at the minute that thinks about that pill for every ill, so it's much, much easier to reach for a tablet than it is to start having a healthier diet, or increasing mindfulness in your day, or having more exercise. But actually, it's just another little driver. You know, we have the net zero agenda, but now we also have the pharmaceutical pollution agenda. And it's another driver for people to think, do I really need a medicine? Is there anything else that I can do? And also for our healthcare, of course, to have that realistic medicine or choosing wisely approach to their practice. So, as I said at the beginning, we have actually changed policy in Scotland. So, when we delivered our climate emergency and sustainability strategy, at the same time, our health boards were given an environmental policy. And within that, in health boards, we now have to consider water stewardship. So, one of the big areas to do that in is to look at pollution from our medicines. I do believe we're the only country within the 4 nations of the UK to have pharmaceutical pollution in our climate emergency strategy and also water stewardship. So we hope that the work that we're doing in Scotland can be spread across the UK and across the rest of the world as well. We are now a recognised national focal point. We are supported in part by the Scottish Government. We have just about a month ago expanded our partnership. So for the past 5 or 6 years, we've been focusing on pharmaceuticals in the environment. But of course, that goes hand in hand with antimicrobial resistance. And whilst we have been addressing AMR in some projects, we are now going to have a new group looking solely at AMR and the environment. Also one on microplastics, because we know that microplastics can actually absorb pharmaceuticals in the environment. So they're a really dense repository for pharmaceutical pollution. And of course, we know our fishes and everything eat microplastics. So if they're a concentrated form of pollution, that pollution is going straight into our food chain at a higher level. And we've been focusing on human medicines, but of course, you know, it's probably 50-50, maybe even more veterinary medicines that go into our environment and can have the same effects as our human medicines. So we will now have an expert group working on vet meds as well. We are always looking to widen our partnership. So if anyone's listening and likes what they hear, please do get in touch with me, because we are obviously needing lots more experts now on these 3 new fields, but also continuing experts on pharmaceuticals and the environment as we take that forward. We are already very interdisciplinary, but we are willing, able, and just dying for more people to join our network. And we're internationalizing our efforts. We have links with new universities and organizations across the world, because, you know, much like we did our work in the pandemic, we don't all need to repeat this. We don't need to reinvent the wheel, and working together is much, much better. And of course, the next presentation you're going to hear from Kelly is about the Pharma Pollution Hub. And, you know, we're delighted to say that we helped Kelly to set this up, and I sit on Kelly's advisory group for that, both doing slightly different things from a different angles, but actually it takes both of those things. We're both working on a systems approach across the pharmaceutical life cycle and across the NHS. So hoping to keep working with Kelly and the Pharma Pollution Hub. I just wanted to give you a few lessons that we have learnt, and it's lots. I get a bit fed up in the net zero agenda with everyone saying, well, we don't have the data yet, so we can't do anything. Of course we can do something. We have to do what we can right now with the data that we do have. It won't be perfect. I'm sure our respiratory prescribing, our strategies just come out in Scotland yesterday about that. I'm sure that won't be perfect. We will learn lots more. We have these new inhalers coming online. We may change what we're doing down the line, but we can only do the best that we can at a particular time with what we've got. Also, people get a bit stymied by thinking, oh, this is never going to happen. Things do take a long time to change. Policy change takes a long time, but we've done it in Scotland. We did it within 5 years. So don't get disheartened. Keep working, keep that vision at the top of your brain and work towards that. No matter how small a step you're taking, every little step counts. And remember that we are all parts of the jigsaw. And if in your work you're not getting as far and as fast as you think you should, are you missing a piece of the jigsaw? Do you have to bring another partner on board? there are loads of hurdles to jump, but we have to find a way of jumping them, or maybe even just walking around the side of them and ignoring them for now. And my last one, and this is why we're all around this table today, is collaborate, 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 because we all do know something that somebody else doesn't know, and we all have a really key opportunity to change the triple planetary crisis moving forward. These are the partners that we're involved in it with at the moment. You can see NGOs, higher education, the third sector, SMEs, lots of people, but always, as I said, looking for more. So if you found that interesting today, please do drop me a line or hook up to me on LinkedIn or Twitter. And this is just a thank you to all the people that are involved in all the projects that I've talked about today. So thank you very much indeed.
Thanks, Sharon. That's a fantastic talk, and there are lots of really appreciative comments in the chat. I guess we have quite a few questions for you, so I'll try to pack them up. One was, how engaged have patients been? You know, how interested are they in less polluting medications?
Yes, so I mentioned the MRC project, and I haven't had time to go into all the detail, Fiona. Maybe at a future meeting I can give you the real detail behind that. But yes, they were very engaged, and I was surprised that actually a number of them had heard about this issue. And of course, since I've started this work 6 or 7 years ago, every day almost, it seems, on the TV or on the news, we're hearing about water companies, probably particularly across England, and their sewage overflows. And some of that is about sewage, but that has also brought the pharmaceutical pollution issue to the fore as well. So they are engaged. And interestingly, in my focus groups, I had quite a few wild swimmers. I'm sure we have some around the table here today. But in Scotland, yeah, they're still nutty enough to go into the freezing water right up here early in the morning. It's great for their health, they say. So they're really concerned about the water that they're actually swimming in. And I think as well, we saw that in the Oxford and Cambridge University boat race a few weeks, where they were being told to stay out of the water, okay, for bug purposes, for E. coli and things like that. But I think public awareness is increasing. But really interesting challenges about changing their medicines. So if they had drug A and drug B and they were equal, absolutely willing to change. But the minute I said to them, well, if this drug takes 10 minutes longer to work or isn't quite as effective, it was like, no, 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 I don't want to do that. So yeah, we have some hurdles there to get over, but I'm sure we can find a way of working with the public to do that.
Yeah, no, good point. And that sounds similar to what NICE found on the impact of climate change in terms of, you know, people's preference if things are equal.
Yes.
There's really great questions from Julie and Laurie, which pick up on the same issue around good to see that we're broadening the perspective from just carbon. And Julie was asking, you know, are the target APIs based on not just volume, but also toxicity? And linked to that, Laurie was asking, you know, is there an eco score, a bit like a nutritional score?
Yes, that was something that we asked in our focus groups, actually, from both prescriber and a public point of view. And absolutely the easiest thing to do would be to introduce labelling like we have in our food, that, you know, red, amber, green, maybe red fish, green fish, things like that. So all very interested in having easy to access information about this. On the toxicity point of view, the work that was done in Sweden a few years ago looked at toxicity, persistence, and bioaccumulation. But we've taken that much further, and we've added in lots of other things like the excretion rate, the mass of drug that's being prescribed that could be going into the environment, lots of other environmental criteria about our wastewater treatment plants, because it's not just about the PBT score. I think we need to take lots more into account.
Great. And so those, because Michael's asking a question around kind of proxies, we have bioavailability or some other proxy that can be considered for future medicines that aren't commonly prescribed.
Could you say that again, please, Fiona? I didn't quite catch that. Do
we have bioavailability or some other proxy that can be considered for future medicines or those that aren't commonly prescribed? So
yes, so Environmental risk assessments are something that pharmaceutical companies have to do to submit their new drug for licensing. These just came into play in 2006. So obviously, probably in primary care, maybe I'm thinking 95 to 98% of the drugs that we use are now generics. So they will not have probably will not have environmental risk assessments. So we do need something to tell us about that. So there's great international projects going on with industry. The Premier project is looking at that, trying to get data, useful data on drugs that maybe don't already have an environmental risk assessment. So hopefully that project will bring more to the table. And certainly my project was a proof of concept. So yes, it can be done, but we'd love to do more. And we really want to get more into the nitty-gritty of having those scores for people having that information. So if we have any funders around the table or anyone who wants to partner us, yeah, please hit me up.
Good point. And then finally from Jürgen, what's the magnitude of alternative for less toxic drugs you were able to identify with a significantly reduced environmental impact versus other standard drugs for the same patient population? I mean, what's the opportunity?
Yes, so that's the difficult challenge. What exactly is the opportunity, and can we succeed in bringing that opportunity? One of the most common, well, three common areas, I guess antidepressants, the whole class of antidepressants, to my knowledge, is quite ecotoxic. We have drugs called SSRIs that we use for depression. Those drugs, they have a lot of awful side effects, and they probably take between 4 to 8 weeks to start working. So quite often what I'll say to clinicians is, consider something else. So we always tell clinicians to think about BRAN. What are the benefits and risks of drugs? What are the alternatives? And what if we do nothing? So the alternative here would be to do maybe online CBT, cognitive behavioral therapy. I believe that the evidence is that for mild depression, it's just, if not more, as effective than the drugs. So let's start patients on that and then ask them to come back. And if that hasn't worked within the 8 weeks, then okay, at least we've deferred the prescription, we've tried something else. So there is opportunity there. Also, let's think about our non-steroidals, our anti-inflammatory painkillers. One of the worst ecotoxic ones is diclofenac. So we do have other drugs in our repertoire, things like naproxen and ibuprofen. All of the drugs, to some extent, have some ecotoxicity issue around them, but it's a better one. So we can think about switching drugs out in our formulary, and then if the first couple of drugs don't work on a patient, at least then we can go to the third choice, but recognizing that we have decreased the overall impact by using the other 2 drugs first.
Great. Well, I mean, as you've already said, there are lots of other presentations you could definitely do for us. We really appreciate working and collaborating with you on a number of issues. And thank you so much for being so flexible and fitting us into your day. We really appreciate it. And lots of really positive comments. And I'm sure there'll be people following up, and, fantastic to hear about all your work. Well, congratulations, really brilliant stuff. Thank you, Sharon.
Thank you, Fiona, and I'll try now just and put some answers to those questions that we didn't have a chance to do.
Okay, that's really appreciated. Thank you.
Thank you so much.
So you already gave a fantastic trailer for our next speaker, Kelly Thornberg, who we have been collaborating with for a little while on her fantastic work. She is the co-coordinator of the Pharma Pollution Hub, and she's very much leading in this feeling of getting people together, getting them to really raise the issue and thinking about what we can collectively do for action. So Kelly, over to you.
Thanks, Fiona. Can you hear me and see the screen okay?
Yeah, it's all there.
Brilliant. Okay, so thank you very much. And yeah, following on from what Sharon's presented, she really is a trailblazer in this field. So I'm honoured to share the stage with her, if you like. But yeah, so today I'm going to talk about actually repeat a little bit of what Sharon's already included about why we need to think about pharmaceutical pollution more. And then I'm really delighted to introduce our new Pharma Pollution Hub. So this is an independent think tank accelerating collective action to reduce the environmental impact of medicines used in UK healthcare. It's been running for a year or two, and it's really been a bit of a seed project funded by the University of Exeter, the Wellcome Trust, and the Medical Research Council, and just to sort of test out our systems approach and you know, establish, you know, how we should take this forward and what we need to do. So to start with, there we go. To start with, then, just talking about why we need to take action, and Sharon's you know, covered a lot of this already, but these are the 9 planetary health boundaries. So and this is the safe operating space in the middle here. So if we want a long-term healthy relationship between humans and our planet, we need to remain within this green circle or within this grey circle. And as you can see, 6 of the 9 boundaries we're already exceeding. There's a lot of focus on climate change. In terms of pharmaceuticals, we know our pharmaceutical manufacture and usage has a substantial carbon footprint, and we've heard today already about some of the fantastic initiatives to address this. Pharmaceuticals also have quite a substantial freshwater footprint. You need a lot of water when you're manufacturing pharmaceuticals, particularly very pure water. But pharmaceutical pollution is really covering these 2, I would say. It's novel entities. So this is things that aren't present naturally, so chemicals, plastics, and including pharmaceuticals. And then this is essentially biodiversity. So you can see that these 2 in particular are well exceeded, and this is really the main sort of area of our remit. As Sharon said, we need to do something here, because the pharmaceuticals we use in healthcare are pretty much constantly entering the environment. So up to 90% of the drugs that we consume are excreted in our urine or our feces. They enter our wastewater systems, and as Sharon said, they're not designed for this. So many pharmaceuticals are not completely removed. It's thought that only 27% of people, and this is one study, return drugs, unused drugs, to the pharmacy for safe disposal. So either, again, they're going into our wastewater, or they're going into landfill where they can leach out into the environment. And manufacturing is another source. In the UK, we have 600 to 700 manufacturing sites. Obviously, there's a lot of manufacturing goes on overseas. This is these levels, these really high levels, this one in India downstream of a suite of antibiotic manufacturing facilities. The river had higher levels of antibiotics than you find in the blood of some patients. That's obviously not in the UK, but it just shows, you know, we have this range of sources of pharmaceuticals from healthcare into entering the environment. Pharma pollution is increasing. So this is a study that looked at 250 rivers across the world, and at over 50% of the sites, they found carbamazepine, which is a neuroactive drug, metformin, which is a diabetes drug, and caffeine, which is officially a pharmaceutical. It's obviously a drug that we all use, well, most of us, a lot. So these are present in 50% of the sites tested. And what was worrying was that at least a quarter of the sites, there was one or more active pharmaceutical ingredient that was present at concentrations that we know cause ecological impact. So pharmaceuticals levels are increasing. They are at low concentrations typically, but they're designed to be active at low concentrations because we want them to not have side effects in our bodies. So we design them to be active as low a concentration as possible. They're designed to pass through biological membranes to reach the targets within our bodies. And often the targets are conserved across species, because if you've got a target that's evolutionary conserved, usually that means it's important. So it's, you know, it's more effective as a target. Sharon's already talked about some of the physiological effects. The evidence base for this is building. And through these physiological effects, there's over a long term, this is contributing towards biodiversity loss. But it's really difficult to measure because pharmaceuticals almost always, I mean, there's examples of vultures in India where populations crashed because of diclofenac use in cattle. But other than that, usually the impacts are long term, and it's very difficult to measure, especially because in the environment pharmaceuticals are present in mixtures of a whole range of other pollutants. It's also difficult to know what the ecological risk is, and Sharon touched on this again. You know, the monitoring that we do. This is the European Commission's Water Framework Directive. The priority list, which is the mandatory monitoring, there are no pharmaceuticals on this at the moment, although hopefully very soon there will be 10 added to this. The watch list, which is voluntary list, has 16 pharmaceuticals, but we use almost 2,000 pharmaceuticals. So this is a very small proportion that are being monitored. And even, you know, this is pretty sketchy, the monitoring that does happen on for the watch list, because it's voluntary. And we don't know whether the UK is actually going to keep aligning with this. There's talks about it not doing so. And as I say, there's this was in Europe. It's very similar in the UK, almost 2,000 pharmaceuticals being used. This looked at those 1,763, this recent study, and showed, you know, for around 2/3, we don't have any monitoring data. This is from the last 23 years, I think. There's no monitoring data at all, and no data on ecological risk. This thin green slice here, 1.5%, are the number of pharmaceuticals where we know what's being where we know what levels are in the environment, and we know what the risk is. So there's huge uncertainties about risk here. And again, Sharon mentioned the Premier project, which is being led by AstraZeneca, and it's a really fabulous project looking to address this data gap. Again, I'll just very skim past this. So, you know, Sharon talked about the risks of antimicrobial resistance. We know we're being exposed to pharmaceuticals in the environment through drinking water, bathing, sewage sludge being applied to agricultural land. We don't know what the impact of these is at the moment. Particularly drinking water, it's at low levels that are thought to not have an impact, but research is really growing in this field now. And then in economic risk, obviously the pharmaceutical industry is so important. You know, economically, economic growth, employment, it contributes an awful lot. So we need to find ways to protect this. And the corporate sustainability targets are now going beyond carbon, looking at biodiversity metrics. So as these start including things like pharmaceutical pollution, this poses a risk to this pharmaceutical sector, and we need to support them to find solutions. Also, between 25 and 50% of active pharmaceutical ingredients are derived from nature. Some of them, obviously, we haven't even discovered yet. So we need to maintain biodiversity for this as well. And then finally, just in terms of setting the scene, our use and reliance is increasing. So this is global pharmaceutical market, which is 1.5 trillion US dollars. This is the UK markets gradually increasing. The number of pharmacists increasing. The number of wholesalers is increasing. 15% of people in England take 5 or more medicines a day now. The cost of drugs are rising more than the annual increase in funding of the NHS. We have drugs that we know are unnecessarily prescribed. And of course, the more drugs we prescribe, the more we have drug dependency issues, the more we have drug reactions, which all have knock-on costs as well. So this sort of paints a picture that we're using more, we're relying more. So, you know, we need to do something about it. So therefore, what do we need to do about it? And we think that there's 3 main issues here. And so we need to find solutions that overcome these 3 major challenges. So the first one is working with all of this complexity. It's a very complex situation. And pharmaceuticals are deep rooted in our society. So how do we work with, we need to work with complexity and uncertainty. We need to balance the competing interests. So how do we balance the substantial human and economic benefits we gain from pharmaceuticals with the environmental risk, especially when there's so much uncertainty around that? How do we overcome the short-term risks? Sharon had pictures of hurdles. I've got a kind of overhang of a climber. You know, we need change at scale here, and we know that that means that stakeholders across the pharmaceutical and the healthcare sectors are going to have pretty substantial, in some cases, short-term challenges to overcome in order to achieve long-term sustainability. So we need to support them to do that. How is the Pharma Pollution Hub doing that? So we think that there's a need for an independent facilitator. Obviously, the One Health Breakthrough Partnership's doing this already in Scotland. We want to do this, at least England, if not, you know, and do other aspects of this. But we want to drive, we think that to overcome this issue of complexity and uncertainty, we need to apply a systems approach to look at the breadth of the situation and the societal depth of the situation. We need, importantly, this is the key, we just need to bring people together, collective dialogue, to so all the stakeholders from across the pharmaceutical life cycle can understand each other's perspectives and co-develop solutions together. And I've heard this already today a few times about the need for innovation. We believe that to overcome these short-term risks, we need to bring in and mobilize the research community, so the expertise and the resources of the research community, and focus that on answering the questions that people need answers to. So, for example, you know, what interventions are available? How do I prioritize them? How do we, let's test them out, what are the costs, what are the benefits, evaluating them, all these sort of questions that we think we need to connect to the research community a lot better to the people that are in the real world doing the you know, working on this. So as I said, our aim is to become an independent think tank, and to overcome, to address these two parts of these two challenges, this is all about collaboration. So we've created the Pharma Pollution Consortium. At the moment, there's 70 members from across all these different sectors. This has been a seed project, so we'd like to increase this more in the future. We just haven't had the resources to do so in these this initial period. Importantly, you know, this is about social innovation as much as anything else, and so we've got academics from all disciplines, you know, social sciences, so economists, policy sciences, anthropologists, historians, and we've also got natural scientists, engineers, you know, all disciplines we have, and that's part of the sort of linking up for the research for change. And we have 5 working groups that span the whole of the life cycle. So we have population health, pharmaceutical design and manufacturing and licensing, healthcare decision making, pharmacy sales, use and disposal, environmental monitoring and management. So each of these working groups looks at different parts of the life cycle and the issues associated with that. And then the third challenge, the systems approach. So this was done at the start of when we set out all of this. So it's published 18 months ago now. And we mapped out the UK healthcare pharmaceutical system as the first step. And I know this is really small, but just to sort of talk you through it, in grey here is the life cycle. So this is design, manufacture, distribution. This is the healthcare sector. And as these lines going down are the sort of waste, so air, solid and water waste. And then this goes out into the environment down here. And just a couple of things to note from this. Oh, obviously, you can see the complexity of it. At the minute, it's quite linear. It's not really a system. It sort of comes from here and it goes down to there. There's not much feedback coming up from the environment up to the sort of upstream steps. So this is something that, you know, we really needs to change. And I know that this change is in progress with carbon. We need the environment to be feeding back into these key decision-making steps in healthcare and policies and the economic decisions. So this is, you know, the lack of feedback is quite obvious from this. The other thing is the fact, you know, when I talk to people in population health, sometimes they say to me, oh, you know, what have I got to do with pharmaceutical pollution? And this shows you that all of these upstream drivers of the need and the desire for pharmaceuticals, this is driving ultimately pollution. And the easiest way here to, at scale, reduce pollution is reduce the amount. So the less that goes into this system, the less that comes out. And so, you know, we need to really be looking at the social determinants of health, the economic factors, you know, the market. We need to be reducing waste, and we need to be trying to look at this feedback mechanisms. So that was our initial systems mapping exercise. We're now at this point, so identifying leverage points for change from across the system. And then in the dream world, the next step is a national action plan with recommendations. So that's, in the future. But for now, we're in this middle step. And what we're doing is we're using this iceberg model, which is a systems thinking tool, to understand the situation, so understand the system for each of the remits of the 5 working groups. So and then use that to identify leverage points. So in the iceberg model, essentially, this is a tool used to understand complex problems. So an iceberg, 90% of an iceberg is below the surface, it's invisible. So if we look at the outcomes, so the 10% that we do see, so let's say this is pharmaceutical pollution, this is underpinned by structures that are just below the surface. And then when we go deeper, there's goals that underpin these structures, and deeper still, it's the sort of mindset or the culture that underpins this. And so we're looking at population health, pharmaceutical design and manufacturing, all the working groups, and trying to understand what is the iceberg for these different remits, and then using that to identify leverage points for change. And we've got a report that's going to be coming out in the summer or autumn this year. But just to give you an example, so what we're doing is we're looking at the icebergs from the different working groups and then bringing them all back together to get a whole systems perspective. And from the systems perspective, we've identified we need to optimize operational structures. So, and they're the ones underpinning the supply, use and waste of pharmaceuticals. We need to transform the sectoral goals, so the economic sector, the health sector, the environmental sector. We need to integrate the environment into these. New business models, for example, that's been discussed already today. Outcomes-based healthcare. There's so much that could be done. And then from a top level sort of whole systems perspective, the deep-rooted leverage points that have the greatest potential for change, we need to evolve societal mindsets. So as a system, because this is a complex system, if you have interventions that focus on one point within the system, it shows you they're unlikely to have change because they're just one little point. Obviously, some points have more influence than others, but what we need to do is collaboratively all work together to evolve the whole system towards more sustainable practice. And these are the sort of societal wide mindsets, so awareness, education, knowledge-based leadership, collaboration. These are all things that we've identified which we need to address. So this is the basis of our roadmap for action. We'll go into this in more detail in the report. And then in terms of the our hub, our farm pollution hub, we're now looking to set this up as a charity and then get funding to continue this work and expand it. And so these are the things that we want to do in the future. We want to keep developing more strategies. We really think that monitoring and collecting data from across the system is really important for assessing where we're at and assessing progress. So, these sort of systems-wide approaches, continuing the dialogue, bringing people together, particularly engaging the public a lot more and bringing them into these conversations, expanding our consortium as well, and research for change, research projects, as I talked about earlier, but not only doing our own research projects, but also we've already run one think tank workshop on life cycle analyses, but really sort of providing an environment for people to come together, to seed ideas, to have these transdisciplinary discussions, and then go off and hopefully just support change as well. So this is all the things that we're doing or we want to do. If you want to get involved, because we're in this transition period at the minute, we'd love it if you followed us on social media, so on X or LinkedIn. We have a website if you want to go and find out more, or there's some like a nice animation on there and some more information. Anytime, please drop me an email if you want to get in touch. Hopefully soon, once we get the charity set up and we get the next stage of funding, we'll be inviting people to join our consortium and we'll be expanding. Of course, as a charity, we're going to be looking for funding. Well, we're doing this at the moment. So if anybody is interested in funding the charity or doing research collaborations or anything like that, please do get in touch. And then finally, just to say a huge thanks to my co-director, Charles Tyler. As you'll see on our advisory committee, we have some fantastic experience, including some familiar faces, Keith and Fiona, and of course Sharon. We have a fantastic advisory committee, amazing working group leads who are really sort of balls of energy for driving change in their areas. Thanks to our consortium, who could not do this without, and of course, thank you to our funders, and thank you for listening. Oh, and before, I was just, in case of interest, this was like a kind of extra slide that I'd added. People were asking before about, you know, which pharmaceuticals, you know, should they look at? And it's very tricky, as Sharon said, but just to note that these are the ones that are being proposed to add to the priority list. So, you know, ibuprofen, diclofenac, antibiotics that we use a lot. You know, these are being added to this list because we know that these have potential issues in the environment, and these are the ones that are on the watch list as well. So, you know, just to give you an example of the sort of compounds. But yeah, I'll stop there. Thank you.
Thanks so much, Kelly, and thank you for all you do. And it's fantastic to be able to support and collaborate your work. Really good stuff. We've had a really good chat going on, and thanks to all the colleagues for sharing what their companies are doing. Great to see. One specific question from Alethea. I mean, do we have any idea, in terms of water pollution, what the impact of global manufacturing for APIs versus human waste is? That's a mind-blowing question, at least for me.
I think it depends on, so no, not a definite answer here, but I think it depends a lot on where you're looking at. So you know, for AMR, globally they sort of say, oh, 70% of antibiotics is used in animal usage, and they have some data on this. For pharmaceuticals more broadly, like in the UK and in Europe, I think overall it's thought, I'm trying to remember what the data is here, but I think it's about 70% comes from the community, and I think it's like 20% from, okay, don't quote me on these figures. I think it's like 70% from the community, 20% from healthcare facilities, and 10% from manufacturing or something like this. Oh, Lethea, you look like you've got better data than me here.
No. The reason I'm asking is that I actually think this is a real issue, especially for the developing world.
Yeah.
And I think we profit, if you like, we benefit from the APIs produced in India. So sorry, this is a bit of a side story, because, you know, obviously I worked in sort of the NGO sector. So where you have areas of high manufacturing of these drugs, you will get in the communities surrounding them things like vancomycin resistant bacteria is forming, which is really unusual. So and resistant tuberculosis, you know, so mycobacterium infection. So I think this is not just a problem that we should be addressing in the West. I think this is a real WHO kind of level seriousness, and a real implication for those communities, for the poorest, because they're the ones who end up drinking that water supply. No, it's just interesting, but yeah, no, I just wanted to know, but it's just, I thought you might have it, but I wouldn't have more than you. There's no way.
No, but it's a really good point, because, you know, in some of these areas, you know, although this isn't happening on our doorstep, we are making this happen. We are buying these drugs,
Yes.
and like you say, and in these countries, a lot of I say these countries, you know, in these low and middle income countries, particularly these emerging economies where pharmaceutical manufacturing is increasing, already quite high in many, you know, they don't have environmental. I talked about how bad our monitoring is. There's nothing there. And yeah, so yeah, I totally agree.
But I think it goes back. We need to ask questions about our APIs. If we bring them in across from China and India, that's when the bulk of them come from. What what then is our expectation, our standards that we put on the communities, around that. So I think that's actually the question, isn't it? Anyway, thank you. It's a great talk. I both love, great double act, by the way. So I thought I'd say that.
Thank you.
Well, on that very positive note, thank you, Alethea, for that instant feedback, and thanks to Sharon as well for answering all the questions in the chat. You might have some comments on some of those, Kelly. We really appreciate both of your work, and Kelly in particular for the collaboration. So I'm really fantastic stuff. And I think one of the points you made, I love the iceberg model and that interconnected system, and it's kind of returning to that interconnected system as we think about circularity, which is our next theme. So it's a great pleasure to welcome Andy Clark, who is a very passionate member of the coalition. Great to have you talking today. And Andy is the head of sustainability and also public affairs for Bayer in UK and Ireland. And he's really been championing this issue of circularity in our conversations as a coalition. So over to you, Andy.
Thank you very much, Fiona. I'm the head of sustainability and public affairs at Bayer in the UK and Ireland. Today I come from a relatively privileged position where I've actually throughout my career spent the time throughout the supply chain. So a lot of time within the sales function, but also time in the supply chain. So I come at this with a couple of different angles as well as the sustainability angle. So hopefully over the next 20 minutes, you'll get some thought-provoking questions. That's my aim. But I wanted to do a disclaimer before we get into it all. This is an old-fashioned disclaimer. Look, this is all my personal opinion. This is not of the opinion of Bayer. This is all about what I think. I'm not an expert in packaging or circular practice, so please take some of this with a pinch of salt. If it's not 100% accurate, these are purely thoughts and ideas about how we could potentially address some challenges or look at potential solutions. So we're going to go through a number of factors within the next 20 minutes or so. There will be some time at the end for a few questions if anybody has any, and I'm more than happy to take some of this offline if anybody is interested as well. But hopefully over the next couple of minutes we'll start getting into some of these, and by no stretch am I going to be able to get into some huge detail. There is such complexities around this topic. I'm only scratching the surface today, so please don't expect there to be huge amounts of detail or huge discussions we can have around that. So let's start off. I think the best place to start off is that we enter this discussion predominantly on the left-hand side of this chart. So within the industry, within pharmaceuticals, we typically sit on the linear economy. We typically produce things, and we typically consume things, and we typically throw things away. Now, please don't get me wrong. Of course, there are so many things going on. There's recycling, there's other practices going on, but typically our industry sits on the left-hand side. And more, we are being encouraged to move to the right-hand side, to really look at the practices that we adopt as an industry, looking at the systemic approach of how the industry can start reusing, recycling, remaking, etc. Now, that is absolutely the right way to go. But what I really wanted to do today was just to bring a couple of thoughts into question of, is it the right thing to do in every situation? Are we looking at it in the right way? Or are there other things that we do need to consider along the way? So I really want to anchor, before I got into the whole topic of circularity, on let's really strip it back and start at the very beginning. What are some of the fundamentals of supplying medicines to patients? You put patients at the center. Everything about this has to be efficacious. The product has to work. They have to be stable products. They have to be safe for consumption, for distribution, etc. Now, these are by no stretch the only three things that are the most fundamentals, but these are three of the really fundamental things that really have to be considered when we are producing and supplying medicines within the supply chain and within this country. If it doesn't adhere to this, then it's just not going to happen. And what really made me start thinking about this in a slightly different dynamic is when you start bringing those fundamentals to the way that we are packaging medicines. Actually, there's some, again, this is not an exhaustive list, but there's some real fundamental requirements for the packaging that we are using to produce and supply these medicines. You know, the medicines, anything touching the medicine or the drug has to be virgin plastic. Obviously, there's sterilization, there's the traceability, the non-toxic elements, the durability. There's so many different things, and I've just put a few here that we have such a hierarchy of needs when it comes to the requirements of those packaging that it's non-negotiable if we're going to deliver those fundamentals that we just saw. So that's just something that adds to the complexity, adds to the real challenge that we are all facing in this industry. And we know that we've got the pressure coming, and it's not just the NHS, we've got other customers, we've got other health authorities who are really putting that pressure on us to look at these circular options moving forward. The decarbonisation agenda is very much looking to circularity as a way of cutting carbon emissions so that we can all hit our net zero agendas. And let's just be really clear, on the right hand side there is just the scale of the problem within the NHS, or the scale of the opportunity, whichever way we want to turn it. We've got over 1 billion prescriptions a year. There's a lot of packaging that's involved there. And we've got over 10 million operations annually within the NHS every year. And again, we all know the equipment involved in those operations is vast. So to really start looking at this in a circular way, we have to really look at the scale of the problem that we're up against and think about how we can start tackling this. Now, when you start looking at that, you start thinking, okay, are we geared up to doing this? And there are many practices already within the NHS in particular that are already doing some fantastic things to really tackle this. But let's be really clear, there's over 150,000 tons of clinical waste every year. There's already a system in hospitals and health authorities to collect and to recycle and redistribute waste. But actually what we're really talking about moving forward in a circular economy is that storage and sorting within hospitals in particular is going to have to dramatically increase. There's going to be administration, there's going to be time and resources to make sure that this is all done safely, quickly and adequately. And that just dramatically increases the complexity of that whole operation that is already complex in a hospital. And in my opinion, doing some really loose calculations on this, and please don't ask me to verify them, I think the costs will go up dramatically. To really tackle this properly and safely, the costs are going to go up hugely just to achieve the things that you can see above on that list. And then it starts making me question, you know, what are the environmental benefits versus those cost benefits, and can there be a right balance that can be struck there? Because what's really interesting about this whole circularity topic is that it's only really addressing from a requirement from suppliers' point of view. It's only really addressing the decarbonisation of the waste. It's not looking at some of the other environmental challenges that we have to tackle as well. And that's something that I really thought was worth highlighting in this situation. And what I thought about that was, actually, isn't it really important that each of us here, now don't get me wrong, there's some incredible people here, but this also involves supply chain professionals, and it needs packaging experts, it needs people from around our organization to all be really clear about the myths that are involved when it comes to moving towards a circularity world. Because we're not just talking about the UK and Ireland here, or the UK here, we genuinely are talking about a global system that would need to change. Because moving things just for the UK to make it circular really doesn't work because of our global supply chains. And then just going back to the slide here, looking at the myths that we need to start thinking about busting to balance the argument, because what I don't want to say is that circularity is bad. I don't want to say that it's overly good. I want to make sure that it's all talked about in the right balance. Plastics on the left-hand side here have had a huge impact and a huge kind of negative portrayal in the media over the last number of years. And don't get me wrong, it's one of our biggest health concerns and the health challenges of our time with what happens with plastic after it's been used. It going into the environment and going into the water systems is a terrible tragedy. But let's be really clear that when you start looking at the amount of resources, minerals, energy, water to produce plastic, it's far better, for all of those than reusing glass, re-sterilizing equipment, re-entering that into the supply chain. The amount of resources used are greatly reduced when it comes to plastic. So therefore, plastic does have a role to play, and there can be some really positive benefits. So this was my last slide. I didn't think it was going to be a particularly long presentation. We didn't have that long today. But what I really wanted to try and bring to the discussion around circularity was making sure that we enter this with a really balanced approach as an industry, making sure that we actually have the correct information. What are the facts that we know for sure out there? You know, what are the actual underlying objectives? Because if it's just to cut carbon, we don't want to be cutting carbon at the expense of increasing water, increasing energy use, increasing the materials and resources needed to underline that system necessarily. And what are the realistic, what realistically can we support? What can we as an industry do? Because in the UK, we are just one cog of a global network very often. So we have to change those whole networks and systems, like we've already said. And also, what's really interesting to me is I've spoken to a number of people around the industry, and everyone is doing some fantastic work on this. We tend to be working on our own projects, on our own supply chains, often in silos, but not all the time. But what are we doing as an industry to bring all this together? And I know that there are some networks that are going on and there are some work streams that are going on, but do we have solutions that work for pharmaceuticals when we're looking at circularity, rather than us just potentially fixing our own problems? So there were just a few thoughts, my Jerry's final thoughts that I wanted to bring. Not too many slides today. I didn't want to do death by PowerPoint, but I really wanted to start thinking about balancing the argument and really starting bringing together some of those kind of interesting areas that we do need to solve as a collective rather than on our own.
Thanks, Andy. What a broad-based but also challenging perspective. I mean, from your perspective, what do you think the objectives and principles are that we should operate from in terms of asking your own question?
Yeah, well, this is purely, again, my opinion. Look, the challenge that I find personally is that all of our targets, the majority of our targets, the majority of our reporting really does sit within carbon. And it's great that we can look at some of these options to reduce carbon. But what I am concerned with, especially with the new CSRD reporting that's coming in, is there are only going to be more and more other things that we have to consider. And I'm struggling at the moment when I've done my research on circularity to really see the collective environmental benefits outside of just the carbon emissions. So my challenge is what do I focus on as my goal? And I haven't been able to answer that yet, which is why I thought it'd be really interesting to kind of bring to the forefront on actually what are other people looking at? What are other people's objectives? Because it probably doesn't help if I have one on my own, and it probably needs to be better aligned.
Sure. And can you tell us a little bit more about CSRD for those who are not familiar with what that actually means in Europe?
Sorry, yeah, throwing another acronym around there. So CSRD is the Corporate Sustainability Reporting Directive. It's an EU non-financial reporting disclosure from a sustainability point of view. It's very broad ranged. So anyone that's involved in any sort of ESG reporting knows that the majority of it in the UK at the moment has been carbon based. It's been emissions based. And this starts bringing in other social and environmental aspects to non-financial reporting. It's not necessarily going to be needed within the UK that soon because it's an EU report. However, the UK could easily create its own version or an offshoot of what it expects companies to be reporting on. So it's just one of those that it's made financial reporting even bigger because it's gone to non-financial and it covers a very wide base.
And I guess it's also an attempt to standardize what all companies are asked, so that when you start looking at investment houses and things, they've actually got a standard way of looking at
absolutely
what the industry's doing. Michelle, you came off.
Yeah, I just wondered, what information and data do you think we still need so that we can start being able to think more holistically and better about this? What do you think's, what would be your top 3 asks, do you think?
Love the question, Michelle, and literally thinking this off the top of my head. One of the things that I've got the mentality of kind of end to end. So I don't just think about the system, I think about the reality of delivering that system as well. One of the things that I spoke to Wendy, and I'm not sure if Wendy's on the line today, Wendy Rayner up in NHS Scotland, because they're quite at the forefront of this, is how can this be delivered effectively through hospitals? You know, we're already asking clinicians and support staff to do an awful lot. How can we bring in, I don't know, 20, 30 bins full of different chemicals, different equipment, etc.? And then how does that get taken away to different waste streams quickly, so it's not a hazard? And then how does that practically enter the very complex global supply chain of pharmaceuticals, and who's responsible for the quality checks across the line? So look, I know I'm getting right to the end of implementation, but that is genuinely, Michelle, one of my biggest kind of thoughts behind this, is that whilst I am a fan of circularity, I think that we do need to find a solution, but I'm really at the end of how do you implement that solution in a safe way because of what we're dealing with here. So the implementation, I would say, it's the collective, I guess, is my second one, is how do we get an industry approach here? Like I said, there's got to be a joined up approach that we can all kind of follow a blueprint towards. Because a quick example, if you look at inhalers as an example, if that's going to be recycled, if that's going to if a component's going to be re-entered into the supply chain, you might be getting products that are not yours originally, or components that were not yours originally. And how do you change your practices and your procurement processes and your manufacturing capabilities to be able to accept non kind of Bayer standard products or components, if you understand? So for me, it's really interesting and really difficult, because what you can't do is just have things that are a big bucket of sterilized equipment that people are picking out saying, well, that's Bayer, that's AZ, that's Roche. It just doesn't work like that. So the practicalities of it, there has to be an industry approach, but also the practicality of delivering it. And I can't think of a third one, sorry.
I think they're doing something in Australia where they do actually they're using all of their prisoners to pick out all the different stuff.
Fantastic.
Right?
But look, I can see it working really well in other industries, but pharmaceuticals, because of our restrictions, I mean, I don't know if the Australian is a pharmaceutical example, but that's
sure.
where
I think it's a device. I think it's a BD thing. I don't know if there's someone from BD. I'm sure they presented on it at a conference I was at, and I was like, oh, it's interesting because it fits the social value piece as well. But okay. Obviously, I'm in med devices, so it's slightly different challenges, but I was interested in your headspace there, and I just wondered, what data do we need so that we know what to tackle first? Because, lots of the drugs that are prescribed are never used, for example, so that's an obvious place, just like lots of devices that are bought expire. And there's all these pieces where we could start to be thinking about it in a different way, which isn't just when we're stuck in the middle of that sort of gnarly problem, it's expanding it out a bit.
Yes. And something we do need to remember is that the many of the components within the pharmaceutical industry did used to be circular. So it's not like we're completely redesigning something new. We might have to do that, but how did it work previously, and how did it work so successfully previously? So we don't necessarily have to reinvent the wheel if an old system could be utilized. I mean, I'm not that close to that and how that could work in reality now, but the reason it changed was for specific reasons. So
yeah,
I don't know if we could go back.
There's an interesting thing in the chat from Kelly saying we don't even have data on what pharma are not used and or returned to pharmacies. That could be a good start. And it made me think about the buyback scheme for bottles. And I was like, Well, if you offered £1 every time you bought your drugs back, I bet loads of people would bring them back, right?
Absolutely.
Yeah, interesting.
Great. Well, Andy, there's loads of comments in the chat and things that you might want to respond to. Julie's been very proactive, saying that not all plastics are created equal, and sometimes the demonization of the material is not useful. Absolutely. And then there is also a good analogy drawn by Michael Cohen on the recent experience of Starbucks, which is perhaps a lesson. So you've really kind of provoked a good conversation there. We really appreciate your open-mindedness in bringing forward that perspective. Always great to have you present, because I think you get us all thinking beyond the day-to-day. So thank you so much, Andy.
Pleasure. Thank you.
And I think you set things up really well for Shaheen, our next presenter, who, as many of you will know, is the Professor of Sustainable Engineering and head of the Sustainable Manufacturing Research Group at Loughborough. And we've been working with him, together with the APHI and others, on his REMED work. So Shaheen, we're really looking forward to what you have to say to us. Thank you very much.
Thank you, Fiona. My name is Shaheen Rahimfat, work at Loughborough University. By background, I am an industrial engineer, so from engineering background. I'm also a member of a research center called Center for SMART, which stands for Sustainable Manufacturing and Recycling Technologies. One of the disadvantages of having the last slot of presentation before lunch is because you come between people and lunch. And one of the advantages of this last slot is that majority of the stuff you were going to refer to, previous authors, presenters have already covered, particularly Andy, who's really brought a number of issues that we are facing as well, although we're working in a different area of medical devices as opposed to pharma. So there are commonality there, and I look forward to catch up with him and share some ideas. So we were talking just now about linear economy and the problems with it. So this morning there was a lot of talk about decarbonization and also issues about water. So my presentation is very much about material, circularity of material. What about material? What about resilience of our capability to access the materials we need to make our future medical devices? We are all very familiar with the environmental impact of overmining, not only on land, water, and air, but also the socio-ethical issues, particularly these days with increased digitalization in our sort of use of medical devices and a type of precious metal and specific materials that we need to be able to make these medical devices. So on one hand, we have overmining and its problems, and on the other hand, we have too much waste coming out of this linear economy. Again, both environmental, but also social, ethical, biodiversity, a huge range of problems associated to this linear economy. And as Andy was saying, is we really need to talk and move towards circularity. It was interesting. I was listening to the conversation about the plastics, and again, I agree that it's not war on plastics, is war on inappropriate use of plastics. And plastic has done wonders in many sectors for a lot of application. But we also have to be mindful that our use of plastic is doubling every 10 years. And there is something to be said to say, is there a way of rationalization of our reliance on plastics? There is then other issues about resilience of access to material. This is the projected requirement we have on cobalt, which is used in lots of digital devices. And the projection currently is by 2030, we are in a deficit of around 150,000 tons of this material. Although the mining is increasing, there is lots of concern around mining of cobalt, particularly in Africa and South America. And knowing all of this problem with the linear economy, if you have a look at the projected waste generation in various regions of the world, we expect it to rise. You would have thought, knowing the problem, we're going to take some steps and stop that rise. But based on current practices, based on current policies, this is going to rise over the next few years and certainly by 2050. So for us, this transition from linear to circular economy is a must. But how do we do that? I think my co-presenters this morning identified the complexities, the challenges, the many disciplines that needs to be involved to be able to achieve that journey. So truly a transdisciplinary type of effort is required to be able to do this. In the case of medical devices, there is this story about perfect storm sort of forming, which for me has formed many years ago. We weren't aware of it. So we have this aging population across the world where need more medical treatment. Increasing range of medical treatments being introduced and offered. There is a growing number of devices used in each of these treatments, and escalating reliance on single-use medical devices. Add all of that to the rising population demanding access to the latest treatment is definition of that perfect storm. The real concern about the resilience in the global medical device supply chains. If we were to carry in this linear approach, would be able to make as many devices in the future and offer as many treatments. As a result, I think most of you are familiar with this document that Department of Health and Social Care developed a medical technology strategy for the next 10 years. It was introduced February 23. And again, no surprise that the first priority there is resilience and continuity of supply of medical devices. In line with this, 5 academics from the 3 universities, Loughborough University, University of Leeds, and Nottingham Trent, came together prior to all of this interest on design for life, which we heard about earlier, and also about this Department of Health and Social Care strategy being introduced in 23. We came together, we had a proposal which was submitted, and we started a project which we refer to as REMED, basically thinking about circularity of medical devices. The project started in September 22. It's a 30 months duration and due to complete in February 25. We have 7 researchers that are working on a range of life cycle issues. This is the approach that we've taken, and I'll explain a bit more. In our core partners, we have a representative from all of the stakeholders in the value chain, all the way from sort of manufacturers, reprocessors, NHS, medics, who's obviously using these devices to be able to get a rounded sort of advice and data from the group of people who are most sort of influential in the use of these medical devices and how they will be taken out at the end of their life and what will happen to their end of life. You may note that in our core partners, a key missing partner is material suppliers. So if you are one of those in this call, or if you have contact, we'll be grateful to be put in touch with one of the material suppliers to these medical devices, because quite clearly one of the key issues about circularity is those material suppliers sort of being involved in the bigger picture, as we're going to talk about it in the next few slides. So we divided the project based on the 3 stage, doing a bit of a due diligence on the product assessment and sort of what's happening, what are the barriers, drivers, challenges in circularity. Then on research and innovation, which we are currently sort of involved, take that life cycle approach that I mentioned, all the way from design to considering materials. And today we've heard a number of times the main challenge being this operational behavioral change, the impact on business, the impact on flow of material, and then economical and business models. So that's also been included. We are also looking at a number of novel reprocessing it was interesting to mention about how we will kind of separate all of this waste, even if it was collected, which I hope to be able to actually provide initial solutions that we are developing that using robotics. The big circle decontamination is just to say that this was a red balloon for us, that at the start of the project we weren't aware of impact of sterilization decontamination, but we are now working with a number of other colleagues in different universities and studying this. So in our first stage, we had a number of workshops, webinars, and with the various stakeholder groups, and try to develop this view of what are those drivers, challenges, barriers, and gaps that are acting as an obstacle for us to move from linear to circular use of medical devices. I'm not intending, because of limitation on the time, to go through all of this, but we have reports that are summarizing the results of this workshops. So if you're interested, please email me and I will send you those documentation summarizing the result of these workshops. At the same time, we had further brainstorming workshops, where we brought relevant people together and said, when we're considering these various stages of life cycle, what are the key issues we need to consider? Because there are many. But what is the low-hanging fruit? How do we start? Where is the starting point? And we gather a number of priority lists on each stage of life of the medical devices, and based on research and innovation on these priorities that was identified through these industrial workshops. So the next stage for us is what are we going to do? What medical devices? Depending on catalogs you look, depending on categorizations in different regions of the world, you have upwards of 20,000 plus medical devices. We couldn't obviously consider all of them with the limited resources that we have. So we use this metrics of value and complexity to be able to find a sample case study product to be able to give us the coverage of all different types of medical devices in use based on their value and complexity. So giving you all these 4 quadrants, starting all the way from low value, low complexity to high value, high complexity, and in between. The reason for this is when it comes to reprocessing, when it comes to collection and all of the other supply chain issues, there isn't a silver bullet that one model fit all. So you really need to consider the nature of the product, how it's used, and be able to devise a specific product or product family solution that can be adopted as you'll see in a way that we're trying to develop these reference models based on these cases of the products. So again, we disseminated this. We talked to our industrial partners, advisory boards, and they said, well, 8 is a good start, is a representative of some of these various groups of products. But in reality, to really provide a good coverage, we need 100 plus type of reference products, case studies, to give us that broad range of medical devices and different use that they're kind of been made in various healthcare settings, both in hospitals and in home cares and stuff. So I'm going to just highlight some of the work that we do under each of these stages. So there was a talk again about inhalers. I was listening with a lot of interest. We are actually trying to introduce design interventions that make either recycling of inhalers, i.e. separation of its material. So we've been looking at different brands, different types of inhalers, and it is really surprising that even when you talk about use of plastics and metal in the standard inhalers, there are different plastics are used, and there are various components within the a metallic part of it. So we are kind of trying to simplify that, use this design for circularity, identify certain ways that you can separate this, and also on the bottom right, you see that we are looking at this really complex problem that if you want to reuse inhalers, not by reissuing it to other patient, but by those who's got a long-term need for this. Is there a way of refilling these canisters at home so it will kind of introduce circularity, extension of life by the single user as opposed to sort of passing it around to kind of different people? Then when it comes to material, I think Andy made this sort of point very elegantly in that we really need to be careful about what we're proposing, and is what we're proposing in reality environmentally more beneficial. So in terms of material, you have to have a look at the material flow analysis. What are we using? What quality of recycled material we get? Where can we actually reuse this sort of materials? Would it be in the healthcare sector? Would it be in different sector? What virgin materials are we going to replace with this sort of recycled material? Is the impact, overall impact of collection and recycling of this recycled material less than the virgin material that you're replacing? So there's a lot of material flow analysis trying to create some of those data that was just mentioned missing. We are looking at business and operational issue. We're developing a number of simulation model. What happens to the flow of products? What happens to the business models, which I just talk about in a minute? In terms of flow through the supply chain, what happens to stock levels? What happened to the procurement procedures? So we'll be able through this digital model to do a number of what-if analysis for our case study products and create some data. We're also looking at health economics in terms of, yes, what will happen? Andy predicted that in most cases, circularity would be more expensive. We believe so as well, but we believe that there is this introductory sort of period that you have to go through until you have the right service providers, until you have the right policies that then impact the health economics of using circular medical devices with a single use. But certainly there is this hike at the starting point. In reprocessing, this is where we were talking about waste sorting. We are actually developing robotic cells that can do sorting. There is number of activities on product recognition. So in a similar way that waste has been sorted in other sectors, in packaging, in municipal waste and so on, we are trying to develop system to sort of automate that waste sorting. On the right-hand side, you see that we take examples of various products, put it through different sterilization, decontamination processes, see the impact on material quality, generate sample recycled material, and through some sort of material characterization to see what sort of secondary use you can make out of them. Can you actually circularly use it within the healthcare? So, for example, use the material plastic that is coming from syringes to make catheter stands, and which has got lower requirement from materials, or is it better to be able to use it in another sector? All of that information goes into a number of reference models for various sort of case study product that we are considering. The hope is that these digitally searchable reference models provide all of the relevant information that we've obtained about each of these products, and the manufacturers and users of different products can actually search one that is closest to their product and find some useful information for them. What are the next steps? We are building our network of collaboration. Fiona has been really invaluable in putting us in touch with more and more of the community. Our user group now exceeds 100. We are developing a call to action document, which again, it was mentioned that we need to bring all of these silo of activities, whether at universities or across various companies together. I'll say about that a bit more. We're doing workshops and webinars. If you're interested in the schedule of those, it's on our website, www.remed.uk. We are planning for the next phase of REMED, the REMED 2.0. So if you want to be involved in the future of this research, please get in touch. And I will tell you about our conference shortly. So this is the link to our call to action document. We co-created this through a stage development through workshops, through meetings, face-to-face meetings with various industrial partners, and now it's going into the second stage consultation, wider consultation based on a survey. So it takes about 10 or 15 minutes to do that survey. If you want to be involved in development of this call to action, please send us an email and we'll send you the link to do the survey. And then in September, 17th of September 24, we will have our second conference. The first conference was in December 23. It was well received. Because of the budgetary limitation, we can only have 150. The call for the conference went out about 2 weeks, and I've been told to date we've already sold out or appointed about 50 of these tickets. So if you're interested to attend the conference, please send us an email and we'll send you a link for the registration. I want to finish by the point that everybody made. When you think about the complexity of what we're talking about, it just appears like a mountain. And we often ask ourselves, can we move that mountain? But our argument is, when you see all of the problems, when you see that definition of perfect storm, simply you come to one conclusion: no action is not an option. So I'd like to stop at this point and invite any questions that you may have.
Great, thanks very much. And yes, moving mountains is quite a good sport, isn't it? But certainly a good challenge. And as you say, no action isn't an option for any of us. There have been some really good comments in the chat. Jürgen Wieland from Novartis has talked about other bits of work, some of which share the same name for connections for you to make. Jürgen, let us know if you want to raise any points on that. And Alethea is interested in your conference, and so I think Keith has put the links in the website. In terms of us as a group, what's the thing that we could most do to help you move that mountain?
I think at the moment there was a lot of reliance on data that we really need to carry out a lot of studies, specific studies, to develop bespoke what we call decision factors in terms of how and the procurement policies for NHS is developed. Because when you talk to each of these actors in the supply chain in isolation, they seem to be all for it. They say moving to circularity and stuff is a no-brainer. But if NHS had a clear kind of procurement policies, then we can match our activities and things to do that. When you talk to NHS people about lack of circularity and stuff, they're basically saying the services are not available to us. The products are not produced by manufacturers. We don't have as many service providers that can deal with our reprocessing. I was interested in talking about waste management. What do we do? And recently I've met with the head of waste management in NHS, Mr. Liam Hogg, and the first thing he said to me is, we're not going to put any more bins in the hospitals. We ran out of space. So we can start from that and go upwards, kind of thing. So yes, there are lots of challenges, lots of data that is needed. From your point of view, is putting us in touch with these key stakeholders. Particularly now we are looking for a material supplier. That is a missing link in our full life cycle considerations.
Great, thank you. And Michelle's asking, what other industries have got most alignment with our waste make up our system? So
as a part of a Centre for Smart, Fiona, you know that we are involved in circular economy of 8 different sectors. So one of the key things that we've managed to do is bring a lot of transferable knowledge from other sectors into this. Is there 2 sectors that quite align and the methods and tools developed in one can be used in the other? No. In medical devices, this risk of infections and decontamination, impact of decontamination on materials is the one that is making it quite unique. But there are lots of things that are done in food and drink. I think this was mentioned again earlier on collection, recycling of plastics. on looking at ways that you can introduce behavioral change. There are lots of models that have been introduced on behavioral change and so on, that I think there are elements and nuggets of gold knowledge from other sectors that can be moved. But I wouldn't think that there is a sector that is totally aligned with medtech and we can just take all of their solutions ours. We need to develop bespoke solutions for medtech.
Okay, and a couple of specific points from Alethea. She wanted to know, do you have any dealings with the Advanced Manufacturing Centre in Cambridge, MDMC?
Yes, we do, and also with MTC affiliate in Coventry, Manufacturing Technology Centre. So there is a whole lot of activities that are going on. This call to action is trying to create this longevity. And other things that we need in this area is longevity. There is a lot of programs that are run for 1 or 2 or 3 years. They don't have enough time. As we know, the innovation cycle within medtech averaging over 10 years from the point of identifying a needs to having a solutions and so on, with all of the regulatory requirements and so on. So we really need a community, a collective approach of bringing everybody together. And currently we are actually in a form of this remit 2.0, bringing people from University of Cambridge into the hub that we have and involving them in these activities.
Yeah, and Alethea is also pointing out that MDMC is actually in Edinburgh and Heriot-Watt. So if you don't have links with them, then I'm sure she'd be happy to connect you.
Yes, please, Alethea. No, I don't have the link to that.
Okay, that would be great. Thanks, Alethea. And then Julie Aspin from Baxter is asking, are there specific material types you're focusing on in terms of wanting suppliers and data?
There's specific sort of at the moment devices that we focus on the digital based devices, things like glucose meters, things like heart monitors, fusion pumps, because of interest in precious metal. So we are particularly interested on material suppliers and sort of manufacturers of digital medical devices to be able to look at that, because they're very interesting. As you know, within electrical electronic, we have WEEE. And WEEE is sort of very complex within different sectors, and there is a lack of clarity of where does the WEEE comes within the medical sectors, particularly when you're talking about infected sort of electrical electronic products within the medtech. Can that be actually processed with the other e-waste, or do we need a separate sort of waste stream to deal with the e-waste within medical devices? Okay.
That's great. Well, there's certainly an offer to connect you there. So, Shaheen, if you could put your email in the chat, people are happy to do that. And Michelle just wanted to finally ask, what proportion of waste is contaminated, do you think?
Well, that's a very good question. And the honest answer is I don't know. Because it really depends on, it's not only about how these medical devices are used, it's about how they collect it. Every trust have got a different sort of a policy in terms of what they're collecting, how they're collecting, who their waste recycler is there. So some of it is about product and their use, but then there are other operational issues that comes that may introduce that cross-infection. So it's a very, very difficult set of data to gather, because there is a lot of variability across UK on it.
Great. Well, thank you so much, Shaheen, for all your work on this, for your partnership with us, and for such a great talk. I think we've had an absolutely fascinating morning. It's picked up on so many issues, just how important a systemic approach is, really the role of innovation, of course, collaboration. And we really hope that, you know, obviously our role as a coalition is to spark new thinking, connect people for collaborations and to accelerate change. And I think this morning's given us so many great examples of how we're at the beginning of many processes, learning from each other all the time. So thank you very much for joining us. We look forward to starting this afternoon session at 5 to 2, and we're going to have more of a health systems approach. First thing, we're going to be looking at international action, both from the World Health Organization, within the French health system, what the opportunities for the NHS are, and then really looking more broadly on the European agenda. So we look forward to welcoming you back at 2 o'clock.